Here I would like to, because this is a topic which can be asked in the theory exam as well as you may have case scenario in the practical exam also. So I have divided this into two parts. One is the acute burns management, which we normally as an intensive care specialist sometimes we are interested with. And the once a patient is successfully managed in the acute phase with several, very considerable degrees or extent of burn, then once the burn wound heals, it doesn't heal very normally unless it is a first degree or second degree burn. So it always results in severe fibrosis and contractures, and patients after about 6 months or a year of the acute burn injury healing, they come back to us for release of these contractures, either for functional purpose or for cosmetic purpose. So that is the second part of the discussion, which we didn't have much time on that day to do that. So you may get a case of post-burns contracture patient coming with a severe contracture of the neck or hands and other places, which will be kept in the examination mainly to discuss about the anticipated difficult airway. Once you know that patient's head and neck is fixed in a particular position, you can definitely anticipate that it is going to be a challenging airway for management. So we will first see the first half of the management, which we discussed on that day when I told that there was a patient coming with a blast injury from the kitchen while working with about 30% or 40% burns. And we discussed how to manage that patient when she comes to the emergency. So in continuation of that, we will now see what is the pathophysiology in acute burns, how patients become so severely hypovolemic in spite of the fact that there is no obvious or overt bleeding or loss of fluid, as it happens in cases of trauma or some gastrointestinal disorders like vomiting and diarrhea. So that pathophysiology, how they lose their fluid and shed it into their own body compartment, is a very important aspect which you all should understand. And when we try to correct it by fluid resuscitation, we'll end up with those fluid going out of the vascular compartment and settling in the interstitial and extravascular spaces also, which results in more edema rather than correction of the circulatory volume. That is the biggest challenge in the management of burns. So we will see how you have to manage that situation. So I'll make it into a. So can I go ahead? Adequate people have come?
Yes, please, sir.
Okay, right. So the first thing when you are in the field where there is an accident or burn happening in the pre-hospital care, patient should be they usually run in panic and then the fire spreads more. So first to stop them from movement, make them lie on the floor and roll them, which is the best method to protect the patient from extensive burns if their clothing or their dress gets fire. So the stop, drop, roll is the safety measure that you have to adapt at the scene or the place of accident. And a rapid survey of the ABC. Here you first look into the CAB. We are now reversing in the ABC survey into compression. If there is a arrest, we start with a compression and then do an ABC survey. And at the field's location itself, you can start cooling the wound by pouring cold water. Any burn, you can immediately pour cold water, whether sterile or unsterile, don't worry. Immediately pour cold water to prevent the further spread of the burn and silent extension of the burn tissue. Then maintain the oxygenation and keep the head end elevated and shift them as quickly as possible. And do the ABC survey, exposure and fluid resuscitation should be started as early as possible. Now the type of burn the source can be a dry heat or a wet heat. The steam boilers and the steam that is emanating from the boiling of a liquid is called a wet heat, and the flame burns are called the dry heat. And another pattern of source of heat is the electrical burns, especially those working in the high tension category, the electricians or the people working in the electricity board, these linemen and other people. If they touch the high tension voltage lines, they get into severe electrical burns, and it spreads very fast. And there is one point of entry and there will be another point of exit in that. And other source is the chemical burn or acid burns, acid or alkali, whichever is touching the skin, that can cause severe burns. And the last category is radiation burns, which usually happens in the war zones, like when you put a bomb or where there is a lot of radiation energy released. So normally we don't come across radiation burns in our day-to-day life. But the other three types or sources are very common. The chemical can also happen, the electrical sometimes happen, but the most common is the thermal burns, either in the form of a flame burn or a moist heat burn. Now, what happens in major burns is there is a massive tissue destruction, right from the skin to the substances or structures below the skin. There is a destruction by the heat. Once that is happening, there is a cytokine mediated inflammatory response happens, which can be at the site of injury as well as at the distant sites in the body. That is how the burns become very, very troublesome, because it not only affects the location or the place where the flame burn or the heat touches the body, but it can also cause reactions in the distant sites in the body. So systemic effects occur in two phases. That is what is called the burn shock in the initial phase, which is called the ebb phase. In this phase only, patient goes into severe hemodynamic instability with lot of pain depending upon the type of and degree of burn, and severe inflammatory reactions happen in this phase. And this is the ebb phase is the destructive phase. Immediately within 24 hours after the sustaining of a burn, the second phase, what is called the flow phase or the hypermetabolic. So nature tries to start its healing process. So a patient who has in a catabolic phase, breaking down all the energy sources to maintain the energy needs, it starts rebuilding right from the after 24 hours. So the second phase, which is called the flow phase or hypermetabolic phase, starts after the first 24 hours. So this was described by one Dr. Cuthbertson in 1942. And this is the sequelae or the drying that happens in burns. If you see on the left hand side, the inflammatory mediators which are released, histamine, bradykinin, serotonin, prostaglandins, tumor necrosis factor alpha, and interleukin 1, which are all common mediators or inflammatory markers. They are all released. So they are all vasoactive amines. So they act on the capillary circulation and make the capillaries very, very leaky and cause cellular shock. And the microvascular changes that happen is the increased vascular permeability that happens just like in your pregnancy-induced hypertension or preeclampsia patients. The same, more or less the same analogy you can think of, where there are also cytokine release causes increased microvascular changes, resulting in increased fluid leak from the intravascular compartment into the interstitial compartment or extracellular compartment. So this causes edema and the more the edema, it starts compressing the tissues more and produces more ischemia. So two factors are working there. One is the loss of intravascular volume, which is not able to deliver adequate oxygen because of the lack of volume. Second is the leaky fluid causing edema compresses again the capillaries, preventing blood flow. Whatever volume is available, it is not able to flow properly. So it decreases the cardiac output. In order to maintain that, there is a severe catecholamine release resulting in systemic vascular resistance, which can also increase the pulmonary vascular resistance, and patient goes into hypovolemic shock. So cellular shock and hypovolemic shock both contribute to what is called the burn shock. Now within the 21st 24 to 48 hours of burn injury, early changes, all the systems are affected. If you see the heart, there is a tachycardia, decrease in cardiac index, decrease in stroke volume, normal or low blood pressure will be there. If the catecholamine release is very severe, BP may be holding, but you should not get cheated by that. Suddenly the patient will crash. So normal BP does not indicate in these cases that their volume status is all okay. So depending upon the extent of burn, you have to do the resuscitation, and it will also increase the peripheral vascular and systemic vascular, pulmonary vascular and systemic vascular resistance. Hematocrit will be initially increased. So don't be happy because it is a fluid loss, and the increased hematocrit is due to dehydration. And CVP values also may be variable, and patients may go in for metabolic acidosis. And the second organ which will be affected is the kidney. You have to keep a watch on the kidney because acute renal shut-in is a very, very common phenomena in these patients due to multivarious factors like myoglobinuria and decreased perfusion. So both can result in oliguria, which can be found out by urine fractional sodium excretion. Is the sodium conserving ability will be lost, and the brain is affected because of hypoxemia and hypovolemia. So patient may become altered, have an altered mental conscious state, and pain response is more increased. And if it is an inhalation injury, there will be lot of pulmonary changes like bronchospasm and bronchoria initially, which may later on go on to pulmonary edema, again because of the leaky capillary syndrome, and produce a state of something similar to acute respiratory distress syndrome, ARDS, in spite of increased oxygen in the FiO2, the saturation will not be holding. So that is the another lung respiratory problem you have to be very careful with. And adrenal glands are hyperactive. They produce more aldosterone and cortisol. And skin being a most important innate barrier for preventing an infection, there is once the skin is lost, there is a lot of chance of getting an infection very easily. And with altered immune response, which we'll be seeing later, will also facilitate early invasion by bacterial organisms. And a little later, when the second flow phase or hypermetabolic phase happens, there is some corrective steps that taken by the body itself. In spite of our, irrespective of our own resuscitation measures, body also tries to control the severity of the burn injury. So all the same changes will happen, but the cardiac index will increase because we do fluid resuscitation, and body also tries to arrest the leak that is happening at the capillary level. But now the liver will be affected in the flow phase because there is an altered metabolic function, there is an altered drug clearance, and the liver blood flow is increased to maintain the normal function, but coagulation factors may be decreased in this production. So patient may go in for coagulopathy. And bone marrow also can be affected in the flow phase, resulting in decreased hematopoiesis, and anemia can result, and the immuno function is also very much decreased. And kidney, again, you have to keep watch on the flow phase also. There will be initially increased glomerular filtration happening, but decreased tubular function happening. So you have to watch out for, again, tubular dysfunctions. And systemic inflammatory response syndrome will happen. And this is the phase where you have to be very watchful for uh, um, managing with protective asepsis so that we don't iatrogenically produce any infection to the patient. Now coming to definition of what is a major burn. This is the common question asked in the examination. Yeah, so there are very many definitions for that. If there is a full thickness burn injury of more than 10% total body surface area, that is called a major burn. Similarly, if there is only a partial thickness burn, but the total body surface area exposed or burnt is more than 20%, and if it happens in very old or very young people, then also it is called major burn. Or if it is more than 25% in an adult, normal adult, that also is called a major burn. Or based upon the locations, burns involving the face, hands, feet, genitalia, perineum, and major joints. All these things come under major burn category. And if the patient also has suffered an inhalation injury in the lung, it is also called a major burn. Chemical burns occurring in the body, they are also termed as major burn. And electrical burns is a very tricky situation because at the point of contact, there may be only a small injury. But as I told, the electrical burn always happens by a mechanism of point of entry and point of exit. So the electrical energy travels through a long distance in the body and gets exited. So you may have a injury at the site of contact, and there may be a injury or a burn at the point of exit also. And in between, whatever tissues through which the electrical current has passed, they may start becoming necrotic and becoming edematous. So electrical burns normally will start increasing in the extent. Whatever assessment you make in the initial phase will be maybe very only 5% or 10%, but over a period of 3 to 5 days, gradually if you watch the patient, the extent may go on be increasing. That is one tricky situation that will happen with electrical burns. And if burns occurring in patients with coexisting medical conditions like diabetes or ischemic heart disease, that is also concerned as a major burn. And if burns associated with other trauma, for example, a burn victim falls down from a high-storied building and also suffers a fracture or some internal organ injury, then also it becomes a major burn. What is the role of anesthetist in a burn patient? That can be, this was the question I had when I wrote my MD exam in 1982. And I answered it in that way because in those days the books never gave much details about the burns management. The chapter used to be only about 3 pages at the most. So I made a classification of immediate, intermediate, and late role of anesthetist. So in the immediate phase, you are involved with the, if you go to the site of accident, then you are helping the patient to get the triage done, segregate the more serious patients from the less severe patients, take care of the airway, take care of their IV access, and whatever pain relief can be provided, or helping them in really get relieved from the entrapment, and all these things can be done by the doctor going there at the initial phase. And you can also stabilize them before you shift them to a major center for further treatment. So airway, IV access, and triage are the 3 things which we can do at the site of accident. Then once they come back to the intensive care, the perioperative care consultant, you become the perioperative consultant. Now, the surgical management of burn patient uh, also will be involved in the, sometimes in the initial stages where you will have to do the quick debridement if the tissues are very necrotic, or if it is a first or second degree, sometimes you have to help them with the wound dressings and later on with the reconstructive procedures. So you can classify them as the initial, intermediate and late management or the role in anesthesiologist. Somebody is sorry, somebody
Controlling your screen,
yeah,
sir.
yeah. You know, somebody wanted to do some. So you can call this as steps in acute burns. One is what is called the ABC survey, which are all of us are know, and quickly make a assessment of the depth and extent of the burns. This is important for calculating the fluid requirement. So we have to find out, and the depth is the one which determines the severity of the pain. The first and second degree burns are very, very painful, but third and fourth degrees, because all the nerves are also destroyed, patients may not complain of much pain in the deeper burns. And airway management is the most important management, especially if the burns is involving the head and neck, or if there is a history of likelihood of smoke inhalation at the site of accident. The second important management is the fluid resuscitation, and providing pain relief, which and our main job as an anesthesiologist anywhere is to provide pain relief. So we have to think of pain relief also, and early antibiotic and wound cover to prevent infection. As I told you that these patients are more susceptible for infection, and intense monitoring of all the vital functions, cardiovascular, respiratory and renal functions. These are three important areas which you have to monitor, and watch out for sepsis, which is the main killer of these patients. Even if they survive for 10 to 15 days, suddenly they will develop severe sepsis and go in for multi-organ failure. So depth of assessment burns, these are all the various categories. Major one is the superficial burn, which is involving only the epidermis. Then there will be a partial thickness, deep second degree, and full thickness or third degree and fourth degree, which involves fascia and muscle. So the as more and more structures are getting burnt, the depth increases. The advantage is superficial pains, though they are very, very painful, they heal very fast without much of residual effects. Whereas the second degree deep burn, as well as third and fourth degree, they produce a lot of um, fibrosis and contractures, which will be see in the second half how they heal. So that will be the problem with them. So the patient will be again and again coming to you for correction of these problems if they suffer a very deep burn. So assessing the depth of the burn, you can use it in a rough calculation. Our patient's own palm equals to 1% of total body surface area. So we can measure that using the patient's palm imprint. And this picture shows you the various depth of burn, how the superficial burn involves only the epidermis, then epidermis and part of the dermis, and the deep portion of the dermis, and full thickness and all that. So this is a clinical picture, how it will look. If it is a first degree or a superficial burn, it looks like just like an erythematous patch. And sometimes there may be blebs also. That will be the picture of first degree to second degree. And third degree is the deep partial burns that you see on the chest of that patient. And fourth full thickness is the patient who has already been intubated and being ventilated. You can see the arm has got amputated already. So, and one Dr. Jackson said that there is a burn wound model. What exactly histologically happens if you see? There is a central area of coagulation or necrosis surrounded by a zone of stasis where blood is there but it is not in active participation, and third is the zone of hyperemia. So this will be a similar picture in head injury also. If you see the brain injury, there is a zone of necrosis then there is a penumbra, which is the area which is in the twilight, then there is a hyperemia. The same thing is also happening here, which is called the Jackson's burn wound model. And commonly we use what is called the rule of 9, which all of you must be familiar with. Head and neck 9, upper limb right and left 9 plus 9, like that. So all multiplications of 9, and we can easily calculate it in an adult patient. The second rule for calculation of the extent of burn, the Lund-Browder burn diagram or the scale, was initially used for pediatric burn assessment. But now they have modified that for adult calculation also. So based on the, if you see the lower half, it is given from birth to adulthood. You can use the same formula where they have given a ready reference to calculate the extent of burn, and the degree of burn also, second degree, third degree is also mentioned. So this diagram can be easily used in all the hospitals to calculate the quick extent of burn. Now coming to the respiratory injury, the commonest question exams ask how to differentiate between an upper airway and a lower airway. This is what I asked in the discussion also. So the airway burns can stop up to the level of larynx, from the nose, oropharynx and larynx. Then it is usually caused by hot air or hot steam, and it causes laryngeal stridor and laryngospasm mostly. So patient will have a severe stridor, and if it is a flame and inhalation burn, you will find the singeing or burning of the nasal hairs, the nasal hair inside the nostrils. And once it goes to the tracheal level, it causes sloughing and infection, and then the patient starts developing a severe cough and bronchospasm. So mostly it stops at the level of the major bronchi. Usually it doesn't go down very deep. But if it is a dense smoke and patient is trapped inside for a long time, then they can develop acute pulmonary edema also because of the irritation and injury to the vessels. And the warning signs are, if the patient has got any facial burns or neck burns, you have to watch out for airway problem. And if he is being trapped in a burning room for a long time, if the patient has got a change in voice or stridor, or if there is a black sputum coming, indicative of soot or burnt tissues, and if the patient is desaturating or is in a respiratory distress, all these things indicate that there is a severe degree of airway burn. And once you suspect airway burn, do not wait. Immediately try to intubate. That is what I asked in the class, how to intubate the patient when he is struggling for breath. So here, first ask about the period of starvation. Make sure that you don't produce an iatrogenic aspiration injury added to this, and induce some anesthesia, probably with ketamine and a relaxant, and intubate the patient as quickly as possible. That is the practical way of managing a acute respiratory distress burn. And this is how the patient's face will look if there is a severe edema occurring and if they arrive a little late. See, already this patient has had a tracheostomy because they could not intubate the patient in the normal way. So they have made a tracheostomy. And this is how the vocal cords and the surrounding structures will look if you put, when you do a scopy and see, there will be severe periglottic edema. So you cannot pass even a normal size tube. So you always must have a smaller size tube. And some people used to cut the length of the tube to reduce the apparatus dead space. Never do that because in burns patient, the facial edema will be increasing over the 24 to 48 hours, as I told. So if you cut the tube, sometimes the tube may become very short and disconnection may happen, or even extubation may happen. So keep the full length of the tube in the oral cavity. Of course, most of us don't do that, but in Western countries, they shorten the tube size to avoid or reduce the apparatus dead space. So direct injury to the nose and mouth, tongue, palate can happen, which is all above the larynx injury. And below the larynx injury, mostly the epithelium is lost, and so it produces the mucociliary activity is lost, and it will produce a violent cough for the patient. Now, the metabolic poisoning that can happen in the sign of place of injury is carbon monoxide poisoning. So, carbon monoxide poisoning can be asked here, or when you talk about respiratory system disease, when smoking is, the details of smoking can be asked there also. Carbon monoxide poisoning is very important because smoke inhalation causes carbon monoxide. So, the knowledge of carbon monoxide poisoning is important for all of the students appearing for exam. So the manifestations will be nausea, vomiting, headache, and hypotension. Sometimes very severe degrees, you can even get convulsions and coma. So if you mention the carboxyhemoglobin, it may be ranging from 0.1% to 50% depending upon the severity. Because it has got a very high affinity for hemoglobin, it doesn't allow the oxygen to get attached to the hemoglobin and shift the OTC curve to the left. So again and again, I used to tell in all the classes, OTC curve shift to the right is right for patients. Shift to the left is bad for patient tissues. Okay. So only when the curve is shifted to the right, it will deliver the oxygen easily. But if it is attached to the left or shifted to the left, it will not deliver the oxygen easily, and it will increase the tissue hypoxemia. And it inhibits the cytochrome oxidase enzymes. So tissue hypoxia and metabolic acidosis ensue. And pulse oximeter may be deceptively showing a normal value because our pulse oximeters cannot differentiate between carboxyhemoglobin and oxyhemoglobin. So they may be showing a normal value. So the common question the examiners ask is, how do you judge or calculate the fraction of carboxyhemoglobin? You have to use another instrument called co-oximeter, not pulse oximeter, but co-oximeter will tell you about the percentage of carboxyhemoglobin. And treatment is quite easy with just 100% oxygen given via a high flow mask for minor degrees of carboxyhemoglobin poisoning or carbon monoxide poisoning. But more severe degrees need up to a standard what is called hyperbaric oxygen. So the more severe the poisoning with carbon monoxide, you may need hyperbaric oxygen to displace that. Another poisoning that can happen is cyanide poisoning, which will bind to the ferric ion in the cytochrome A3 and produce lactic acidosis despite adequate fluid resuscitation. And it is a mitochondrial poisoning also. So it will prevent the formation of the oxidative phosphorylation and ATP release. So it is a histotoxic or the cell killing poisoning. So you have to treat that properly with if you suspect that, you have to give the anti-cyanide treatment also. And it can also cause mechanical blockage by the prevention of rib movement. So full thickness chest burn acts like a armor. It doesn't allow the ribs to move freely. So it prevents the excursions of respiration, and that may cause a reduced ventilation. So it acts like a restrictive airway disease. And these type of chest burns may require early excision to release that compression so that chest expansion will happen. And early lung protective ventilation should be carried out if you suspect any respiratory insufficiency. And mucolytics like N-acetylcysteine will help in clearing the airway, and you have to give adequate antibiotic prophylaxis to prevent ventilator-induced pneumonia. Now coming to airway management, initial management of inhalation injury is propping up the patient to 30 to 90 degrees, high flow humidified oxygen, bronchodilators, physiotherapy, and fiber optic scope in intubated cases for pulmonary toileting. These are the various equipments that you can use. So early intubation to be considered if there is a stridor, if the patient's GCS is less than 8, if the patient shows severe hypoxemia by ABG or by clinical desaturation, or if there is severe hypercapnia, and if there is full thickness burns of the neck, then immediately intubate, because the thickness, the tissue edema will become more and more and cause severe compression. And later on, it may be difficult to do a scopy and intubate, or even with a fiber optic, you may find it difficult because there will be clotting opening also will become very narrow, and deep facial burns, oropharyngeal edema, and any patient with more than 40% total body surface area burn, you have to think of intubation. And choice of intubation technique depends on the expertise of the operator. Very skilled people, experienced people can easily spray the oral cavity and even intubate in an awake patient without any anesthesia. But if you are a beginner, it is better that you make a thorough assessment of the airway. Don't land up in a situation of can't intubate, can't ventilate scenario. Make an assessment, keep a senior help by the side, and then try to induce anesthesia after ascertaining the full stomach status and with all adequate preparation for intubation. Now, fluid replacement is the next biggest treatment that you have to give. There are two formulas commonly used. As I told in the class earlier, there are umpteen number of formulas described, but the commonly used formula is the Parkland formula, described by the Parkland Hospital by Dr. Baxter and Shires, where they used only lactated ringer. And Professor Krishnan described the advantages of lactated ringer in the fluid class, and it is more or less isotonic with plasma, and that is the reason why it has been chosen as the fluid of choice. And their calculation is 4 ml per kg per percentage of burn. So you have to calculate based on the patient's body weight and percentage. And this calculated volume is given first 8 hours, you give 50% of that. So there is an example also given at the bottom, 70 kg man with 60% burns. So you simply multiply 4 into 70 into 60, which comes to 16,800 ml. And this 16,800 ml, you give the first 8,400 ml in the first 8 hours, and the rest of the 8,400 ml in the remaining 16 hours. So, and that first 8 hours starts from the time of injury and not from the time of arrival at the hospital. So, the first 8 hours is only from the time of injury. And in the Brook formula, they are using both lactated ringer and colloids. So instead of giving 4 ml, because they are giving colloid, they have reduced the total volume to 2 ml, out of which 1.5 ml will be the crystalloid and the colloid will be 0.5 ml. And you calculate according to that. So if you calculate according to Brook formula, it comes to 6,300 ml of ringer lactate for 24 hours and 2,100 ml of colloid. So the advantage what they claim of Brook formula over Parkland formula is, in Parkland we are giving fully crystalloid. So there, because I told you there is a capillary leak, the tissue edema formation is more by using Parkland formula. Whereas by using the Brook formula, because there you are also giving a colloid, more fluid is retained intravascularly and the tissue edema component is less. That is the advantage of Brook formula. But I don't know, for some reason or for the reason that you may not get colloid in all the situations, Parkland formula is very commonly followed in most of the institutions, and Brook formula is only in selective centers. Now coming to the how do you assess whether you are adequately giving the fluids or not, whether your fluid resuscitation is doing the correct job or not, that is assessed by first urine output monitoring. So 0.5 to 1 ml per kg. So you always have that urometer attached bag. Don't just connect it to a simple bag where you have to tilt the bag and then see the volume of urine excreted. Always connect a urometer bag so that you can measure the exact volume every hour and make a calculation. Then blood pressure should be maintained within normal range. Heart rate may be variable. CVP may be 3 to 8 millimeters, and fractional excretion of sodium it should be less than, if it is less than 1%, it indicates hypovolemia. And one creatinine ratio also will tell you about the renal involvement. So, but the blood pressure, heart rate, and CVP are not very reliable. So, urine output is be the most important criteria. That is why it is given as the first monitoring. So, as long as urine output is maintained well, you can be happy that your fluid resuscitation is normal and okay. Now, factors involved in the operative outcome. When to do a surgery, how whether the patient will withstand any remove the scarectomy or debridement of the dead tissue. It depends on age of the patient, extent of the burn injury, what is the mechanism or source of injury, whether there is associated inhalation injury and the lung involvement, and whether the airway is patent or edematous, hematological issues like anemia and coagulopathy, whether you have adequately resuscitated before taking up the patient for this debridement procedure, and whether there is any associated organ dysfunction which is already there. And these patients always develop gastric stasis. So you have to be aware of that for prevention of aspiration. And elapsed time from injury, because as I told you, first of 24 hours to 48 hours is the F phase, then the flow phase. So initially they will be in a catabolic state, then they start going on to hypermetabolic state. So that elapsed time will tell you in which phase they are, and if there are any associated injuries or presence of any coexisting infection, and they may have altered drug response to the painkillers, induction agents, neuromuscular blocking agents, all the drugs we will see little later will be having an altered response. And what is the magnitude of surgical plan? How much area they want to do the debridement or the scarectomy, and challenges may be there with vascular access, and you have to assess the patient's mental status. If they have already got a altered sensorium, that patient may have problems in giving anesthesia and recovery. Now, for pain management in patients with burns, first degree, second degree, they have been using a lot of combinations. Mostly initial stages they were using morphine, and morphine and midazolam combinations were given. Then later on, when dexmedetomidine has come into market, they have started using dexmedetomidine. And so very severe cases when they are on ventilator, they have used propofol infusion also with morphine infusion. And if they are not ventilated, you just use dexmedetomidine on morphine. And for chronic acute burns, patients who have been in the hospital for months or more than, sometimes they stay in the hospital for 2 months also to completely heal the wounds. There again, they have been using a combination of lorazepam and morphine. But in my institution where I used to work, I have used this combination, what is called the KTM cocktail, where we initially, as soon as the patient arrives, and if they have first and second degree burn with severe burning pain, then we mix a 2 ml ampule. Ketamine is available, which is preservative free. You take that 2 ml, which contains 100 milligram of ketamine, and you take another 2 ml of tramadol, which contains 50 milligram per ml. 2 ml contains again 100 milligram of tramadol, and there is 1 ml ampule of midazolam, which contains 5 milligram of midazolam. So total volume will be 2 plus 2 plus 1 will be 5 ml. To this 5 ml, you add 45 ml of saline in a 50 ml syringe, and fix it to the infusion pump, syringe pump, and infuse it, start infusing at the rate of 2 to 3 ml per hour. So this gives a very good pain relief. This is a sub-anesthetic dose of ketamine, and with a mild opioid like tramadol, and midazolam causes anxiety relief. So this we have found very useful, and this infusion we give for the first 2 to 3 days for these patients. And if at all, when you want to do some dressing change or an IV access approach, then we increase the flow rate to 5 ml to 6 ml per hour, which also acts as a partial anesthetic also. So this is the cocktail that I am been using in my practice, which is quite useful. Now, why it becomes very difficult to manage the pain in burns patient? Because there are two types of pain which I told you in the last class. One is the ongoing pain from the burn itself. Second is the procedural pain which we cause to the patient. The ongoing pain is mainly by the superficial or first or second degree burns are the most painful ones. And the procedural pains are caused by the dressing change, excision of the scar, line insertion, physiotherapy, all these things cause the procedural pain. And these patients develop hyperalgesia and allodynia and opioid-induced hyperalgesia. All these terms, all of you heard during the pain class by Dr. Gautam Das. So these changes in the perception of pain happen in these patients, which makes them depressed also, especially patients who do self-immolation as a suicidal attempt. These patients develop a lot of psychiatric problems, so they go into depression, which also adds to the component of pain. So these are all the reasons why their pain management is very difficult. Now coming to the inflammatory and circulatory changes, there is a massive release. All these things already I have this thing. There is a protein leakage leading to hypoproteinemia, and this is how the tissue edema happens. So these are all the how edema formation happens in the first 21 to 2 hours. Then the interstitial integrity is lost, and cortic gradient is changed, and progressive intravascular fluid loss and hypovolemia. Now coming to the injury to the airways and lungs, this is already we have seen. This is another slide which describes the various things. So pneumonia and sepsis, and ultimately that will be the reason for death even if the wound is healing well. And thermoregulation is very, very important in these patients, especially larger the extent of burn. These patients are likely to become hypothermic. They may become cold. So vasodilatory activity is lost, piloerection, all the mechanisms to retain health, heat is lost in these patients in the initial stages. But if a patient develops high temperature, it indicates sepsis. So the initial patients will be little hypothermic. So never use very high AC in the intensive care or the what is called the barrier nursing, where you do the ambient temperature should be only about 32 degrees centigrade at the most. It should not be very cold like 16 to 18 as you do in the OT. And their loss by evaporation is also increased, almost 4,000 ml per square meter in children and 2,400 ml per meter square body area in adults. So to prevent hypothermia occurring, keep the ambient temperature between 28 to 32 degrees. Inspired warm any oxygen supplementation, you must warm the oxygen, warming blanket, and warm all the IV fluids that you give. So take care of prevent hypothermia. And immune response is very much altered because of the loss of skin. It's a mechanical barrier, and the other methods of loss, or there is a lot of chances for infection occurring by IV cannula, urinary catheter, central line, tracheostomy, etc. And bacterial colonized eschar overlaying a wound full of proteinaceous fluid risk is there. So the oozing that is happening at the burn tissues, it forms a good location for bacterial infection. That is why you must keep the dressings changed once they become soaked and shows a little bit of yellowish discoloration. You have to keep changing the dressing to prevent any infection occurring. And in hematology, there may be hemoconcentrated initially, and so hematocrit is a very poor guide to assess the transfusion. So you have to watch out whether after giving adequate fluids, if still the hematocrit is very low, then only you have to transfuse. Platelet count and coagulation derangements can happen because of consumptive coagulopathy. And renal and GI involvement, the renin-angiotensin aldosterone secretion, that thing is cycle is activated to retain more sodium and water. And drugs and myoglobin, sepsis, they all can cause nephrotoxicity and kidney injury. And excessive tissue necrosis and hemolysis can cause hyperkalemia. This is a very important thing. So, and in the GI tract, acute gastric dilatation happens in the early stages, and the paralytic ileus will be there, and curling ulcer will happen in the long run. So you have to give them the so-called sucralfate, which covers the ulcer formation and protects the mucosa. That has to be given for all cases. And you can give proton pump inhibitors also. Then they can also develop abdominal compartment syndrome, acute pancreatitis, and A calculus cholecystitis. All these things are very common in these patients. Now, coming to the vascular access, you have to have at least 2 large IV lines. Any patient with more than 20% burns, don't depend on a single line. Start simultaneously, because when the areas are available, you must catch them and get a IV access. Once you lose the initial time, the whole body may become slowly edematous, and getting an IV access will be very, very difficult. So as soon as the patient arrives, secure as many IV access as possible. Normally we do it one on the upper body and one on the lower body. So if the legs are free, I always start one IV access in the leg and one in the upper limb if it is available. Or you go for a central access as early as possible, so that fluid resuscitation can be done rapidly. So that is a very important thing. So depending upon the location of burn, you can access the subclavian or femoral for central access. IJV will be mostly difficult if it is the head and neck, or subclavian also will be difficult. So you have to go for only femoral in those cases. Now the recent approach is you have to do a wound infection, remove the necrotic tissue as early as possible, so that infection and sepsis does not happen. Now coming to the fasciotomy or eschorotomy, this is the surgery that you will have to do in the first few weeks or first 10 days of these patients are admitted with burns. So the 4 P's of this are pain, pallor, paresthesia, and pulselessness. So the compression by the edema may occlude the pulse. So if that happens, you have to do a removal of that scar as early as possible. It's not scar actually, it's a dead tissue. So first 4 to 14 days is a very important period during which you have to remove this dead tissue. So how to take a decision whether you have to do an early eschorotomy or a late eschorotomy? If your resuscitation is very good and patient is hemodynamically stable, then you don't have to worry. You can go ahead and do the eschorotomy in the early phase itself. But if you have problem in stabilizing the patient, one day his BP is holding, urine output is good, next day there is a drop in urine output, BP drops, then you have to aggressively increase the resuscitation. If such waxing and waning periods are there, then you wait and stabilize the patient and then take up. So ultimately the decision to operate should be based on the patient's hemodynamic stability, sensorium, urine output, kidney function, and temperature, based on the absence of sepsis. All these things will only determine whether to do a early eschorotomy or wait and do the removal. Now coming to, this is the classical way they do that, especially the chest. You can see they have made an incision. It is nothing but releasing that contraction, the tightness by the edema. So you make an incision along the anterior axillary line on both sides and then connect them by transverse incision. In the hand, you have make an incision on the radial border of the fingers and the dorsum of the hand. This is how this procedure is done. And the challenges in giving anesthesia for this procedure is, again, airway will be difficult to manage. So you have to make a thorough plan whether you are going to do a awake fiber optic intubation, or whether you can manage with the LMA if there is no pharyngeal or laryngeal edema, or whether you can go for a conventional scopy and intubation. All that has to be assessed well in advance. then make sure that the patient is having a normal temperature. Don't allow them to become hypothermic intraoperatively. Placing the monitors may be a challenge, and aspiration prophylaxis has to be given, and this can be done as an elective procedure. So as much as possible, starve the patient and then go ahead and do that. Patients may require more analgesics because by the time these patients come for this procedure, they have been used to receiving a lot of analgesics for the pain. So they become tolerant to that. So they may require more dosages. And if you plan for control ventilation, they may require more non-depolarizing muscle relaxants. They may come out of the relaxant much more faster than the normal patient. And the usage of suxamethonium is a very important discussion that will be always asked. So you can do an inhalation injection if you prefer to maintain a airway with a spontaneous respiration. Then thiopentone and propofol may cause a sudden hypotension. So you can have a ketamine as an induction agent, or I always give part of ketamine and part of propofol. Even though there is a preparation by itself called ketofol, we are not having that. So I always give 50% ketamine, 50% propofol, which maintains the stability and makes the patient go under smoothly. And then go for a non-depolarizing muscle relaxant. Avoid ketamine from 24 hours of post-burn period to up to 1 to 1.5 years. Various books give various regimes, but it is safer to avoid suxamethonium wherever possible for intubation. And you can use endotracheal intubation, LMA, which all I have said already. And intermittent doses of ketamine also with fentanyl will be an ideal choice. So suxamethonium to be avoided because it produces hyperkalemia. And why it causes hyperkalemia is because of this presence of extrajunctional receptors. That is receptors which sprout up on the surface of the cell membrane. These receptors are more in number and they stay open for a long time, so that causes a sudden release of potassium into the circulation, which can cause arrhythmia. So this is how the difficulty in monitoring the leads and probes can happen. And this is the this is the actual part of acute burns management. So the important surgery that is done for acute burns is escharrectomy. And then they may come for skin grafting for covering the wound. So initially they may be covering the wound with a little bit of collagen or some other dressing. Later on, once all the dead tissue has been nicely excised and good granulation is coming up, they may come for a skin grafting. So, and then they wait for the whole wound to heal by itself and discharge the patient. So this is the acute burns management which will be happening there. Now we'll go to the next part. What happens is patient has been managed with good IV fluid resuscitation, good wound healing, and with all the healed wounds, they have gone home. But after 4 months or 6 months, what happens? The skin starts contracting. Wherever you have put a graft, it may start contracting, and that may cause a little bit of problem for the patient. So this second part is the anesthetic management of a post-burn sequelae. So this is again the depth of burn which you have to assess first degree, second degree. Burn wounds usually heal by two methods. One is called the restitution and another is called the substitution. In restitution, what happens is the structures which have been lost are restored. For example, if you in first degree burn, even the hair follicle will start growing back in the patient. Whereas if the deeper the burn, what happens? All the superficial structures that come out from the dermis, they are all lost. They will not grow back. So patients who develop deep second degree to third degree burns, when their wound heals, you will not get hair growth on that. You will not get the sebaceous gland growing there. You will not get the sweat glands. So that skin will be just like a mosaic pattern. Okay, that is called substitution. So the wound heals only by these two methods. So the restitution occurs when the depth according to the histology up to the stratum papillae. Appendages in the survive in the partial thickness burns are pilosebaceous units and sweat glands. So this is the picture of the epidermis as a dead tissue which will be normally falling every day. That doesn't count into that. Below the epidermis, at the topmost portion of that is the papillary zone, and up to that, if it is lost, it will get back all the contents in that, like the erector pilae, sebaceous glands, sweat glands, everything will regrow. Whereas if it goes below that, it will not regrow. So that has to heal only by substitution. So the sequence of events of epithelialization, cellular detachment, migration, proliferation, and differentiation. Substitution occurs when the depth is more up to stratum reticular, and healing by substitution with unspecialized connective tissue, which results in the formation of a scar. Okay? So it is not the same tissue which is growing, it is an unspecialized connective tissue. So the cross-linking collagen is the fiber which is a molecule which will come and start growing in that area, and it will be cross-linked with glucosane cross-links to make them stronger. So this collagen is the one which helps in, that is why we always use what is called a collagen dressing for that initially to cover the wound. And burn wounds, full thickness, loss of skin, the wound will contract because of the interaction of fibroblasts, myofibrils, and collagen. Epithelialization from the margin to the so if you have a circular or a square-like wound, the epithelialization will start from the margin and come towards the center. So that will pull the normal tissue surrounding, and that is how the contracture starts happening. So this is the pattern of wound healing which happens, macrophages coming, myoblasts, and all these things. So the post-burn scars are, there are various types. They are divided into immature and mature scars, atopic, hypertrophic or keloid scars, stable, unstable scars, depigmented and hyperpigmented scars, and malignant scars. Now in this picture you can see both mature and immature scar. The area which is all brownish, they are all mature scars because all the vascular changes have been replaced by the fibrous tissue. So those which are looking quite brownish, they are all mature scars, whereas those which are looking little pinkish with vascular appearance, they are all immature scars. That means they are still having a lot of blood supply. So the why this differentiation is be known is, if a surgeon unknowingly wants to operate on this case, immature scar will bleed more. So you will be caught unaware if you don't reserve adequate blood, you may land up with a severe hemorrhage on the table. So mature scars bleed less. So the surgeon should know the difference, and he must take up the scar excision only when they have become fully mature, so that you can avoid unnecessary bleeding on the table. Now, what is the difference between an hypertrophic scar and keloid? That is sometimes usually the problem that you have to heal. The main thing is keloid, they remain, hypertrophic scar remain to the border of the original wound. They don't grow beyond that. Whatever scarring happens within that original border. Whereas keloid will extend beyond the original wound. That is the most important difference that you have to know. For example, many ladies have multiple punctures for wearing the earwear in the modern days. They usually have one in the lobule as a child. Then as they grow, the fashion is to pierce their ears many times at along the helix. Those patients may develop a severe keloid on the back. If you see that, it is only a small puncture wound, but the keloid grows into a very large area. So that is how you have to differentiate. So this is the classical example of a hypertrophic scar, and this is the keloid that happens after a ear piercing. Okay? A small hole made in the ear grows into such a big scar. This is called the keloid. And anything on the pressure point, if you develop a scar, it will break again and again. This is called an unstable scar. And in this case, you can see there is a leukoderma like white center, which is a depigmented scar, and the sides of it are all very dark, which is a hyperpigmented scar. And this scar is one which has turned into malignancy, which is called a Marjolin's ulcer. So you can find all the edges are everted and the scar is having a lot of raw area. So this has become ulcerated. So this is called a Marjolin or a malignant scar, which has become, scar which has become malignant. So the long-standing effect of the scars is deeper tissues are affected in full thickness burns and skin contracture. So they can cause shortening of muscles, tendons, and neurovascular bundles, and joint dislocation or subluxation also can happen, and bone deformity can also happen in these patients. Now coming to the skin graft, prevention of contraction of skin by graft application is done to heal the wound when the wound is fresh and there is a good healthy granulation. Now this is a very healthy granulation. You can see the nice redness of this basal area. So if you put a graft on this, it will nicely accept and it will heal. And what are the types of skin graft that they usually push are meshed and non-meshed skin grafts. So by meshing the graft, you will get a larger area because you make a lot of multiple holes there, and whatever collection is there underneath that, because you have to scrape that granulation tissue and apply the graft. So whatever serum oozing or any collection happening will all come out through the meshed graft than on a full intact graft. So this is how a meshed graft will look like, with a lot of buttonholes there. And the scars are made up of collagen and elastin, which are malleable in the initial stages. So early scars can be molded by giving them a lot of support like splints and other things, so that you can avoid a surgery. So you can stretch them and splint them and prevent a contracture. So continuous monitoring and treatment of scars from the beginning is important to prevent a permanent fixation or contracture. And this is how the collagen, which is cross-linked, will appear. Now, timing of surgery, no contracture release during the active phase of healing and scarring. And excessive bleeding because of increased vascularity will happen. And graft also will not take up if you do a grafting in the early stages. And it will cause more vigorous contracture when you interfere in the early stages. And whatever is amenable to physical therapy like stretching and splinting, that should be attempted first. A mature scar advantage, as I said, will be soft and supple. Dissection plane is easily identified and it is avascular, so less bleeding will happen. Now, what are the exceptions where you have to operate early? One is the eye. When the eyelid is everted, causing what is called ectropion, and exposes the cornea for injury, then that must be attempted easily first. And then incapacitating contracture of the neck. Patient is not even able to eat properly by lifting his chin, and all the food is drooling down. Then that requires early surgery. Similarly, microstoma, narrowing of the mouth, preventing eating. So nutrition will be lost if you don't correct it early. And crippling contractures of the hand, contractures of both knee and post-burns raw area, all this need early surgery. So this is a classic example of ectropion of both the eyelids, especially the upper eyelid should be corrected first. So here they have released the ectropion and put a graft to the upper eyelid so that the cornea is now completely, see the first A picture, you can see both the cornea are exposed. After release, and the picture C, you can see the cornea is nicely covered. Second step, they have to release the lower eyelid and do a similar procedure to close the entire eye. Similarly, this contracture, you can see the mouth, nose, neck, everything is tightly bent. So this requires early release for the patient to eat properly. And this is a microstoma where the mouth is very much narrowed, so patient may not find it easy to eat and maintain their nutrition. And this severe contracture of the both hands, this lady will find it very difficult even to comb her hair. Okay? So she will require assistance. So this contracture should be released as early as possible. Similarly, the contracture of both the knees, which will prevent ambulation, and this is the contracture with the raw area. So this requires early wound coverage, otherwise it will get infected. Now, what is the anesthetic challenge in this management of scar contractures? Common difficulty is getting an IV access, positioning the patient, difficulties in application of monitors, which are all common to earlier acute management also, and tolerance to drugs in repeated surgery, suxamethonium contraindication, psychological behavior. If you see all the problems which were there even in the acute phases, but only when it comes to the question of contracture neck, you will have problem with airway management, which we'll be seeing little later. Now, scars can be simply excised for cosmetic reason, or if it becomes hypertrophic, or if it becomes keloid. These are the reasons why. So, in hypertrophic scar, excision and closure can be done, and it can be large scars. You can do what is called a serial excision and closure, or you can do what is called Z plus T or VY advancement and try to close that. So this is an example of a large hypertrophic scar, which they have done what is called a serial excision, and then you can see a nice little small line in the area where there was an ugly big scar. Now, ectropion of the eyelid requires early repair to prevent loss of vision. So you have to release and do a full thickness graft. So this can be easily achieved by a local block with a supratrochlear and supraorbital nerve block. This is what we used to do in our hospital. And lower eyelid you can manage with an infraorbital nerve block, and even local infiltration and harvesting of the full thickness graft can be done from the thigh or the region where you want to take a graft. So all the procedures of this ectropion management can be managed easily with local blocks. So this is the supraorbital nerve block where you give the injection at the supraorbital nerve area, and the next problem is the microstoma, where you have to release the angle of the mouth to open the mouth more. So this also can be managed with infraorbital and mental nerve blocks. And if the patient is refusing, or if it's a very dense scar to prevent a local block, that you have to go for a nasotracheal intubation if GA is contemplated. So this is how you do a infraorbital nerve block. You can in fact palpate that infraorbital notch or infraorbital opening by palpating below the inferior border of the orbit, and this will be usually a little bit medial to the ala of the nerves, and you can approach it both from exterior as well as intraoral approach you can do. So this is how the intraoral approach of inferior block is done. And mental block also you can do both external as well as internal, and block the nerve for then coming to the most important clinical situation where contracture neck will be kept in the examination. The challenges faced are difficult airway. Being a neck surgery, it may cause a lot of bleeding, and positioning the patient may be difficult. Hypothermia is very common, and postoperative pain and immobilization is very, very important, because if the patient keeps shaking his head, the graft applied may get dislodged. So you have to make a proper planning, and communicating the risk involved to all team members is very, very essential. And readiness to achieve surgical access to airway in cases of can't intubate, can't ventilation. Both will be discussed well in advance. Awake fiber optic intubation will be the first choice if it is available. If the patient is not cooperative, you can induce anesthesia, and especially in children, you have to do this technique of asleep fiber optic intubation, and awake blind nasal intubation under topical anesthesia. This is what we used to commonly do in our hospital because of want of fiber optic scope. And this is how the awake oral fiber optic intubation is done in this picture. But this patient is actually not a very severe contracture case. And in asleep is indicated in children and uncooperative adults. And technique of asleep fiber optic intubation, what you have to do is connect all the monitors, have and help of an experienced second anesthetist, ensure oxygenation at all times. That is the most important point you have to remember. Induce sleep with titrated doses of propofol. Spray and anesthetize the airway with local anesthetic. This is what is called the spray as you go, SPAGO, which is one of the questions asked in the theory exam also. And proceed with fiber optic intubation while the patient breathes spontaneously. Okay, so never paralyze the patient when you do a sleep technique also. Placement of an oral airway or LMA may help to maintain patency if there is any obstruction to the airway before intubation. Then awake blind nasal intubation, which is a technique which most of the older generation anesthetists were very familiar with because of the lack of fiber optic exposure. So you have to get informed consent explaining the procedure to the patient, inform the pressure sensation the tube will produce. Most of the patients will be afraid that it may cause pain during doing that procedure. So you have to counsel them and make them understand that it will be a pressure sensation. Inform about the need to keep breathing with open mouth without holding breath. This is a very important instruction you should tell the patient. They should not hold the breath or try to swallow. They should all the time keep breathing with an open mouth and not retracting the tongue inside. Inform about the inability to phonate when the tube remains in trachea. So once you have successfully intubated, you have to tell in advance to the patient that he will not be able to talk. Because I had one experience with an IAS officer coming for a procedure where I had to do a awake blind nasal intubation, and I succeeded in the first attempt. But patient became little panicky and showed signs that he wants to write something, asking for a bit of piece of paper and pen. Then he wrote, "I am not able to talk." Then I have to tell him that until I remove the tube, you will not be able to talk. From that day onwards, I used to tell all my patients that once the tube has gone into your air passage, you will never be able to talk until the time is the tube is removed. So that assurance should be given to the patient. Now in the steps 2, all monitors should be there, especially pulse oximeter. All resuscitation drugs and should be readily available. Good working suction is a very, very important thing. Keep an IV access. Adequate pre-medication with midazolam and glycopyrrolate can be given. Avoid opioids. Now, few drops of, if you are planning for a nasotracheal intubation, you have to put xylometazoline, which is available as Otrivin or Nesivian drops, which can be put in the nostrils to do vasoconstriction so that bleeding will not happen due to any injury while passing the tube. You have to ensure that adequate nasal block of sensory nerves are there. So the nerve supply to that area is by anterior ethmoidal, long and short sphenopalatine nerves, nasal branch of anterior and superior alveolar nerves. These are all the nerves, and in the oral cavity it is glossopharyngeal, and at the glottic it is the external branch of superior laryngeal nerve. This anatomy question is very, very commonly asked in the examination, so you should be aware of that. And this is the picture of the lateral wall of the nose. When you want to anesthetize the nasal cavity, one of the questions in the theory exam is the anatomy of the lateral wall of the nose. So you have the turbinates, and in between you have the concha, and the septum is there. So all these areas should be adequately anesthetized. And soak the ET tube in warm water to make it soft. So the regular ET tube that we usually use, plastic tubes, are little thick and dense. So to make them soft, you can soak them in warm. Don't use boiling water, just use lukewarm water and keep it so that it will become a little softer. Select the tube one size smaller than the one used for oral intubation. Lubricate the nose and tube well with a anesthetic jelly like the 2% xylocaine, jelly, or water soluble jelly, KY jelly, anything will do. Insert the tube through the nostril and advance listening to the breath sound. So here you are not visualize anything. That is why it is called the blind nasal or blind tracheal intubation. So only the breath sound is your guide to approach the glottic opening. When the tube enters the trachea, breath sounds diminish but air flows continues. The patient will be unable to phonate. That is the first sign. You ask him to say his name, he will not be able to tell his name. So that is an indication of a success that your tube is in the right position. And connecting to the breathing circuit and see the reservoir bag movement is another method. And capnography is the ultimate objective method. So once you connect the capnograph and you see the waveform pattern occurring, that is an indication that you are doing it in a successful manner. And don't be satisfied with one or two capnographic tracings. You must have a standard 6 tracings coming, because sometimes when a patient has taken a carbonated drink and if the tube goes into the esophagus, still you may get 1 or 2 tracings as a, which will look like a capnograph, but after that it will all disappear. So the standard guideline is it must get 6 tracings continuously. Once intubation is successfully done and the tube is confirmed, note the length of the tube at the nostril level, because once you do an extension release of the neck contracture, what will happen? The tube will migrate out. So unless you know what is the initial length at which you have intubated, you have to maintain at the level or even sometimes push it inside if it has migrated out. So once the tube is in position, then you can give a IV induction agent and paralyze and control the ventilation. Now, when fiber optic scope is not available and blind nasal intubation fails, what are the options? This is the common question the examiners are fond of asking. So talk to the surgeon about the need for cooperation from his side to achieve a quick release under local infiltration. This is the first option. But make sure that you will be able to mask ventilate the patient. That is a very important pre-assessment that you have to do. You can give sub-anesthetic doses of ketamine, maximum 0.5 milligram per kg body weight, and ask him to release the contracture. These are the 2 methods. Or you can maintain, if you are able to mask ventilate and maintain a spontaneous respiration, you can go for an inhalation induction with an IV painkiller like small doses of fentanyl or sub-anesthetic doses of ketamine, and also ask him to release the contracture sufficient for scopy and intubation. Okay. Once the satisfactory release is achieved to perform direct scopy, patient can be given additional doses of induction agent and neuromuscular blocking agent, and intubation can be done. So always have help. This is a very important point to remember. On completion of surgery, ensure ease of reintubation by performing a laryngoscopy before extubation. So once the surgery is released, don't immediately extubate. Make attempt to visualize the glottis and see whether you can reintubate the patient in case of requirement or emergency, and have a fully awake patient. Now, Tumescent local anesthesia was practiced in the institution where I worked for a long time. We have done more than 90 to 100 cases of severe contractures purely under Tumescent local anesthesia. So the release of contracture is possible under this. Tumescent, the word tumescence means swelling. It was introduced by Jeffrey Klein, a US dermatologist, mainly for liposuction in morbidly obese patients to avoid the complications of GA. Now, what is the composition? His Klein's formula was normal saline 1000 ml, in which 1% lignocaine 50 ml was added, and the adrenaline or epinephrine 1 ml was added, sodium bicarbonate 8.4%, 12.5 ml was added. This is what is called the Klein's formula. Then there was another person called Hunstead who used ringer lactate instead of saline, and he used 1% lignocaine 50 ml, epinephrine 1 ml, and his reason for adding ringer lactate is it causes less pain compared to normal saline. But in our institution where I worked, we used to add 30 ml of our 2% plain xylocaine in 1 liter of saline. After removing 50 ml, 30 ml. Along with that, another 10 ml will be removed for adding 10 ml of soda bicarb, and 1 ml of epinephrine will be added. With that, we used to add 1500 units of hyaluronidase also. So hyaluronidase helps in spreading the solution evenly throughout the site of injection. Otherwise, the injection may get localized and look like a bleb when the surgeon operates. Okay. So how to calculate the dose? Klein proved that doses of 35 to 55 milligrams of kilogram of lidocaine also was safe. So that is how we used such high quantum of lignocaine. Our normal teaching is 4 milligram without adrenaline and 7 milligram with adrenaline. That is the maximum dose of lignocaine that has been advocated for a long time. But the Tumescent has proved it to be wrong by even going up to a maximum of 55 milligram per kg. But the reason why it is happening is because of the adrenaline, there is intense vasoconstriction and the absorption is very slow. So by the time the whole thing gets absorbed, the dilution becomes so low that such large injections does not cause any toxicity. The advantages of TLA is large volume can be injected to cover larger area, excellent hemostasis. If you have to see that field to believe that it can make a paperweight operative field with no bleeding at all. So the surgeon hardly requires any use of cautery or ligatures to stop the bleeding and causes hydrodissection so that you can separate the scar, and the surgeon is finding it very easy to excise the scar, and can assess the extent of release achieved by asking the patient to move the head. Because the patient is remaining conscious, you can ask them to stretch their neck and see whether they have adequate release, and less infection because of the bacteriostatic effect of lignocaine, and because there is not much of bleeding, the graft applied takes up very well. In our institutional study, we found 95% primary graft take. Only 5% had a small loss of graft loss. Whereas the previous cases done under GA with no Tumescent or no hemostasis, majority of the patients were repeatedly coming for secondary grafting with loss of graft. Now the technique of doing it is by injecting with either a needle or a cannula. I will not go into that. I will just show you the pictures of how it is done. So there is the special cannulas are available. This is not done for a contracture. This actually we do for an abdominoplasty, where you can see I am having a 50 ml syringe which is loaded and then keep injecting it. We can also use the 1 liter bottle saline with all the components mixed and use it as an IV infusion and connect it to this cannula and inject also. So the complications, some of the complications are the large volume inserted can cause little overhydration. If the patient is a very small built person and you inject sometimes in liposections, you inject up to 2 liters or 3 liters, that can cause overhydration and pulmonary edema. But this I have not experienced or come across in my practice. Lignocaine can cause conduction block, and patients usually have a slightly slower sinus rate bradycardia. And epinephrine in some patients can cause arrhythmia, but because it is so diluted, it produces only local effect, and majority of the times we have never come across any arrhythmia due to epinephrine. And delayed bleeding, this is one problem which we have seen. Sometimes, till the surgery is over, there is no bleeding at all. But once when the effect of epinephrine is gone, there is a vasodilatation, and then patients are brought back with bleeding, especially if they have surgeon has mixed any small bleeder which is constricted because of adrenaline and opens up later, that may cause bleeding. And the anesthesia for requiring skin harvesting is another problem. You can give local for the neck or site of surgery, but for the skin harvesting, again, you have to use some form of anesthesia, either as a nerve block or a subarachnoid block or a supplemental GA. And limitations, it is suitable for neck release contracture and cover the resultant area with skin grafting alone. But sometimes surgeons prefer to do a free flap because contractures, with a skin graft, it can again go in for contracture. So they may require a free flap. At the time, it is mandatory that you have to give a general anesthesia for them. Long duration procedures make TLA as a sole anesthetic unsuitable. So if the surgeon is very slow and he takes 3 hours, 4 hours, it is uncomfortable for the patient to lie awake still. So you have to use some sort of TIVA or intravenous sedation for that. So this is the free flap cover for a neck done in our institution. So they have taken a full thickness fasciocutaneous flap from the thigh. It is called the anterolateral thigh flap, which is fixed in that area. And contracture release in the upper limb, it has to be done under regional techniques. You can do it under axillary block. You can do it for lower limbs. You can do it under spinal or epidural block or nerve blocks can be easily done. And disadvantages for positioning may be difficult in some cases, and discomfort for the patient to lie awake in a long time again. Hypotension may be happening in high block, and shivering after spinal is another problem which has to be faced. Now, considering GA for contracture release, GA is ideal for long duration surgeries. If difficulty is not anticipated, then GA with endotracheal intubation or a supraglottic airway will be recommended. Suxamethonium is avoided for fear of hyperkalemia. Adequate pain relief by multimodal analgesia with blocks and non-opioid drugs will be ideal. And prevention of post-op nausea, vomiting, especially after neck release and contracture release of the neck is very important because that may soil the wound and spoil the and cause infection. And prevention of hypothermia and post-operative shivering is very important. So this is how the whole thing ends. Right. Thank you.